Hi everybody, welcome to today's seminar. We're just going to wait a couple of minutes longer while everyone joins the seminar. So please just bear with us for a couple of minutes as we wait for everybody else to join. Hi again. So we were just waiting there for people to join. I think we've got about 50 people with us today who registered, so that's about who's here. So we'll probably get started now. So today's seminar will very kindly be delivered by Vital and Claire, and it's entitled Ethnic Inequalities in COVID-19, What Do We Know So Far? And this is drawing on Claire and Vital's expertise from recent publications and membership of UK and Scottish government groups. So the seminar is going to last around 40 minutes, and then we're going to open up for a question and answer session at the end. And these can be asked by raising your hand, and I'll unmute you, and then you can ask your question. Or please, as we move through the seminar, you can add any questions that you have using the chat function, and I'll read them out at the end as well. Also, if there's any tech issues throughout, please let me know by sending a message in the chat function, and I'll be able to see that as well. I'll be here, although I'm going to turn off my screen. I'll be sort of monitoring the session as well to make sure everything runs smoothly. So again, I'd just like to really thank Claire and Vital, who are really busy, for giving up their time to deliver this seminar. And I'm now going to pass over to Claire, who's going to start the seminar.
Thanks, John, and thanks very much for the opportunity to present today. So first of all, I'm going to give an overview of some of the research we've been doing looking at ethnic inequalities during the pandemic, and this is using data from UK Biobank and Understanding Society. So just a quick outline of my presentation. So first of all, I'm going to go through some research looking at ethnicity and the influence on COVID-19 outcomes, the more direct outcomes of the pandemic. I'll then go on to discuss briefly some research on ethnicity and the indirect impact of the pandemic, so things like mental health and health behaviours. I'll then kind of summarise those bits of research and go on to discuss some of the challenges that we've encountered throughout this period in terms of research. And I'll then hand over to Vital to cover a bit more of the exciting stuff, including like the theory behind ethnic inequalities and COVID and a broader overview of the evidence base. So one of the first pieces of research I wanted to highlight is on ethnic and socioeconomic differences in COVID, and this was using UK Biobank, and it was a study, it was now published back in May, so it feels kind of a bit out of date by now, but it was a collaboration across the Institute of Health and Wellbeing and with colleagues from the Institute of Cardiovascular Sciences. So we looked at, using UK Biobank, we looked at data from around 400,000 participants based in England, and we looked at participants specifically based in England because their baseline data was linked to Public Health England COVID test results within England, and unfortunately not in Scotland and Wales at the moment. So back then, testing was mainly based within the community. So at that point, we had around 950 positive test results, and the majority of these were more severe cases. So the people tested positive when within a hospital setting. So we were interested in looking at the relationship between ethnic group and risk of COVID-19. And we looked at ethnicity defined in different ways, which I'll discuss a bit later. We also wanted to look at to what extent the inequalities were accounted for by a range of different factors, so socio-demographic factors, including, importantly, country of birth, and also whether participants worked within a healthcare setting at baseline, and also socioeconomic factors such as education and deprivation. And we also wanted to look at pre-pandemic health conditions and behavioural risk factors. So what we found, as now a range of studies have demonstrated, that ethnic minorities have quite a high risk of COVID-19. We looked at 3 specific outcomes, so risk of being tested for COVID, risk of testing positive, and risk of testing positive in a hospital setting, which reflected the more kind of severe outcome as you move towards the right. So when compared with the white British group, in particular South Asian groups and Black ethnic groups had higher risk of COVID-19. So that was testing positive and testing positive in hospital, so a more severe infection. And it was interesting that the associations got stronger as you move towards the right, so a more severe outcome. So it was not just because ethnic minorities were being tested more. And when you accounted for different factors, so including country of birth, being a healthcare worker, and socioeconomic factors, the risk decreased and was attenuated, but it didn't completely get rid of all these inequalities. And importantly as well, when you compared white ethnic groups, most of them didn't have a heightened risk of COVID. There may be some increased risk amongst the white Irish group, but not compared to the South Asian and Black groups. And when we drilled down into more detailed ethnic groups, it was important to notice that there were some important differences between particular groups. So particularly amongst South Asians, the Pakistani groups had heightened risk of COVID, and also the Black Caribbean groups had higher risk compared to the white British. And again, these increased risks weren't accounted for by the factors we looked at. So another study I wanted to highlight, again, using UK Biobank, but this time focusing on more younger participants. So these were participants who were of working age at, well, during the pandemic, and who were employed at baseline. And we looked at this was a study led by Miriam and also Leah Demu, based at the unit. So we looked at occupation and risk of COVID-19. And in terms of occupation, we grouped participants into kind of groups of essential workers. So essential workers were people who worked within healthcare, social and education, and other jobs such as food, transport, and the police. And this piece of work, although it wasn't, our main aim wasn't to look at ethnic differences, due to the small numbers within ethnic groups, when you break it down by occupation, we grouped participants into white and non-white essential workers and looked at their risk of COVID-19. And obviously there are limitations of grouping into these broad groups, and which I'll go on to mention a bit later. So what we found when we looked at the association between occupation and more severe COVID, so this was a slightly different outcome. So looking at testing positive within a hospital setting, but also mortality due to COVID. We found differences by race. So essential workers had higher risk of severe COVID, but this was much higher amongst non-white groups. So non-white essential workers had heightened risk of COVID. Non-white, non-essential workers had heightened risk compared to, sorry, slightly mixed up there. Yeah, white essential workers had slightly higher risk compared to non-essential workers who were white, but the increased risk is much more noticeable amongst non-white essential workers. So it seemed like people's occupation was kind of modifying the effect of ethnicity on COVID. And one of the potential explanations that has been kind of played out in the media has been the role of vitamin D. So vitamin D has been hypothesized to reduce the risk of COVID, but also perhaps explain differences by ethnic groups. So again, using UK Biobank, this was a study that I was involved with, but was led by Claire Hasty in Public Health. So she looked at risk of COVID-19 in relation to vitamin D status collected at baseline in UK Biobank. And she found that when taking into account vitamin D, the increased risk amongst ethnic minority groups in terms of COVID was still substantial and not really affected by their vitamin D status. So that was some of the more direct outcomes of the pandemic, but we've also been looking at some of the more indirect effects of the pandemic, so effects on mental health and health behaviours. So for people who are interested, this study can be looked at and read in the Journal of Epidemiology and Community Health. And the aim of this piece of research was to look at mental health and health behaviours, so comparing pre-lockdown and during lockdown, using data from Understanding Society. And we looked at a range of different factors that might be contribute to worse mental health outcomes. And one of the factors we looked at was ethnicity. So for people who aren't familiar with Understanding Society, it's also known as the UK Household Longitudinal Study. And it's a representative study of the UK population. And normally people are interviewed face-to-face, online or via telephone. But during the COVID-19 pandemic, people have been interviewed approximately monthly from April up into July, and then there's surveys collected in September and November. So we compared data from pre-pandemic, so that was during wave 9, which was collected in 2017 to 2019, with data collected during the peak lockdown phase, which was like the end of April this year. And we looked at mental health as measured by psychological distress. So this is using the General Health Questionnaire, and it looks at a different range of symptoms of mental health, poor mental health. So, so if you have trouble sleeping or worrying, and we defined people as having psychological distress to a clinical level as a measure of 4 or more symptoms. So that likely reflects probable kind of common mental disorders. And we also looked at health behaviours, so looking at the frequency of alcohol intake and binge drinking, as well as smoking and e-cigarette use. And for this analysis, we did cross-sectional analysis and also longitudinal models. But I'll just present the cross-sectional results because when we looked at different ethnic groups, we could only do descriptive statistics by kind of more detailed ethnic groupings. So what we found was, again, what other people have found in terms of a large increase in psychological distress when you compare pre-pandemic with the lockdown phase. So this is evident amongst all ethnic groups, particularly white groups, but also there seems to be probably a bigger effect amongst Asian minority ethnic groups. When we looked at alcohol consumption by ethnicity, it's a slightly better story. So whilst adverse alcohol consumption, including binge drinking and the frequency of alcohol consumption, that's increased amongst white ethnic groups. Amongst ethnic minority groups, alcohol consumption is much lower, and also doesn't seem to have increased as much amongst whites compared to white groups. So on the whole, ethnic minority groups have healthier alcohol consumption patterns. So this probably isn't a factor in their kind of more severe outcomes of COVID. So just to summarize, we, in terms of our research using the UK Biobank and Understanding Society, we found that ethnic minority groups have been both directly and indirectly adversely affected by the pandemic compared to white majority groups. And this disproportionate impact is not fully explained by the factors we looked at, including occupation and pre-existing health conditions. So there's probably more fundamental causes at play, which you can't as easily take into account in your models. So things like structural racism may be underlying the patterns we found by ethnicity. So some of the challenges that I've encountered during the past few months in terms of the research, sometimes it's quite a difficult trade-off between the categorizing ethnic groups in terms of the theoretical meaning behind these groups and also statistical power and terminology used. So a statistician will criticize you for including groups with very small numbers of an outcome. But if you group different ethnic groups together, then you're also criticized for grouping totally heterogeneous groups together. And it's been good that there's more of a focus on ethnic inequalities in health during the pandemic in some ways, but there's also been a rush, I think, towards doing this research, and also sometimes not a lot of thought behind the terminology used. So I think it's definitely important to think about these issues. Another challenge has been the speed of research. So we wanted to try and do quick research, but of high quality, that has an opportunity to impact on policy. But this is sometimes not possible if you submit to a journal and then they take months and months to review the article, and then the analysis becomes out of date. So I think this is important in terms of pre-printing your research. But there's also issues around whether or not you should press release your preprints and things like that. And I'll just now hand over to Vital, who'll go into a bit more detail and more interesting stuff about the theory behind ethnic differences in COVID, and a bit more of a broader overview of the evidence base. Thanks for listening.
So hi everyone, thanks Claire. I'm not sure that I will necessarily be going into more interesting things, but I will at least try and cover some different things. So there we go. A few things before we get going, just to mention some potential conflicts of interest, and in particular that this talk doesn't really reflect, doesn't necessarily reflect the views of any of these governmental organizations that I've been involved in. Okay, so what I'm going to try and cover today is give you a sense of why there might be ethnic inequalities and how they might arise at different stages along the COVID pathway, try and give you some insights into what ethnicity as a variable means, and then kind of wind up by briefly mentioning some of the policy responses and further research that's happening. So I suspect that probably everyone who's attending this seminar today has heard that, at least in the UK, there's been higher risks of dying from COVID amongst many ethnic minority groups than the majority white population within the UK. And this is just an illustration of that. So what we can see here is all the columns that go above the horizontal line, above the x-axis, reflect a higher risk of dying from COVID. And as you can see, this was data from the early stage of the pandemic and age standardized mortality ratios. And many ethnic minority groups had quite substantially higher risks of dying from COVID. Now, something that I think, while that's probably very widely appreciated, something that isn't always understood as well is that actually that pattern of findings is quite different to the more recent historical patterns of mortality within England and the rest of the UK. So what we can see here is, in the turquoise, reflect mortality rates prior to the pandemic, whereas then the lower bars reflect mortality rates during the pandemic period. And what you can see is actually many ethnic minority groups had either similar or lower mortality rates prior to the pandemic than the white majority population. This is data from England, but similar data exists for Scotland as well. Whereas during the pandemic, we saw quite much larger increases in mortality. Much of those deaths were coded as being directly due to COVID, but also many of the increase in deaths were coded as not due to COVID as well. So why might this be? Why? I'll present some data that Hilary Thompson and some colleagues at UCL have been pulling together from an ongoing systematic review, where we've looked at ethnicity alongside other social exposures to look at COVID-related inequalities. And we can think of harms in terms of direct COVID mortality arising as a consequence of different stages along the disease pathway. So it could be that ethnic minorities are exposed to the virus more often, and that might lead to greater levels of infection. And that infection could potentially be asymptomatic. It's possible that amongst those who are infected, ethnic minorities might be more vulnerable to developing clinically important disease. So we can think of that as a differential vulnerability. And then out of the people who have clinically important disease, so for example, people who might be in hospital, actually their prognosis might be worse. So it might be that ethnic minorities experience differential consequences. And so that could, for example, be reflected in a greater risk of either dying or ending up in intensive care, or those types of adverse consequences of having clinically important disease. So, well, what does the broader evidence suggest about each of these stages? Well, if we're interested in trying to understand, do people have differential exposure to the virus? One thing we can try and look at is whether there's evidence from blood tests, so serology tests, often referred to as antibody tests, to see is there evidence that people show kind of evidence under a microscope of having been exposed to the virus and their body having mounted an immune response to the virus. So when the Office for National Statistics in England has looked at a random sample of the population, so a representative sample, what they found is actually all the ethnic minority groups they looked at had much higher chances of showing evidence of previous exposure to the virus. And as you can see here, that was often a doubling in risk or thereabouts compared to what they defined as a white majority population. So that suggests that greater risk of experiencing at least asymptomatic infection or exposure to the virus is an important part of the story here. How about when we look at things like being admitted to hospital? So apologies that this slide is a bit busy. Basically, this is a summary of some of the existing epidemiological evidence where the bulk of which has come from the UK and the US. And what you can see is each of the data points represents an individual study. Everything to the right of the vertical line suggests a higher risk amongst ethnic minorities compared to, in the case of the US and the UK, a white majority population. And what you can see is most of the analyses seem to suggest that there's a greater risk amongst ethnic minorities of ending up in hospital. And importantly, this seems to be across quite different ethnic groups as well. So that suggests that this isn't likely to be due to some kind of genetic or biological difference, given that actually there's not likely to be many kind of shared genetic variants across these very heterogeneous ethnic minority groups. When we think about the next step of that pathway, so people who are admitted to hospital, do ethnic minorities who are admitted to hospital have a worse outcome? So that might occur, for example, if there was a poorer treatment that was being received in hospital, or if people were actually getting to hospital later. And what we found is in the UK data, there's some suggestion that there might be worse outcomes amongst people who are admitted to hospital in terms of them being more likely, ethnic minority people being more likely to be admitted to critical care. However, when we look at the broader evidence base, actually the pattern is less clear. So it's not totally clear the extent to which that's a really important contributor. It's worth noting on that last slide, in comparison to the doubling we mentioned when we looked at viral exposure, actually we were talking about only quite small increases, so 20, 30% as opposed to 100%. So how could we make sense of these findings, and why might there be these ethnic inequalities and COVID outcomes? So something I wanted to just try and tease out a bit is thinking about ethnicity. So often people confuse the idea of ethnicity with the idea of race. So historically, race was presuming some kind of biological difference, generally based on visible physical characteristics. But actually, from a scientific point of view, there's very limited support for there being genetically distinct races. But looking at race can still be very important, but much more to understand the impact of racism. So how a society might treat different groups differently based on how they look. So in contrast to that idea of race, ethnicity is a much more multidimensional concept where we can identify a few different elements to it. So the first thing to note is it's ethnicity is usually defined as a group of people that share some kinds of common characteristics, and they might self-identify or are sometimes identified by others as belonging to the same ethnic group. And different dimensions include, as well as the idea of shared physical features, so for example, shared skin color and so forth, that might be traditionally associated with race. Actually, there are also potentially shared cultural factors, language, diet, religion, and so forth. So it's worth noting that actually each of these different dimensions of ethnicity could have their own impacts on the risk of experiencing COVID-19 or the risk of experiencing harm as a consequence of COVID-19. So it's possible, for example, that some of these aspects of ethnicity could be protective while others could be harmful in terms of COVID-19 risk. And when we think about, for example, the lower mortality rates that were often seen amongst minority ethnic groups prior to the pandemic, probably an important contribution to that is what's often referred to as the healthy migrant effect, which is migrants are often self-selecting to move to a new country and are therefore often healthier. So the relationship between country of birth and health outcomes might, for example, then be quite different from other aspects of ethnicity. Something I wanted to try to tease apart a bit was actually trying to differentiate mediators from confounders. So within epidemiology, we often think of confounders as things that we need to statistically address within our analyses, whereas mediators are part of the explanation. And unfortunately, there's been a real lack of understanding of what some of the explanations might be and how they might operate. So, for example, in a few days ago, there was a scientist who has advised the UK government and argued that, well, structural racism is not a reasonable explanation for the higher risk of illness and death amongst South Asian people, but focusing on factors like jobs and housing would help much more. Well, so the problem with that is actually issues about housing, employment, and so forth. They're all the mechanisms through which structural racism would operate. So we need to really be clear that we shouldn't be adjusting for things that are on the causal pathway, and they are likely to be important explanations. So something we've been trying to think about is what are the different pathways through which COVID-19 inequalities might arise. So I've mentioned some of these already. So this idea of differential exposure to the virus, differential vulnerability to experiencing infection or clinically important disease, amongst people who have important disease experiencing differential consequences, but then also even amongst people who recover, the social consequences of having been unwell may differ across ethnic groups as well. So, for example, if long COVID turns out to be an important problem, it could be that ethnic minority groups might be more likely to work in insecure employment and therefore more likely to experience job loss as a consequence of having had COVID infection. A lot of the control measures we're taking in the pandemic may not necessarily be reaching all of the population in an equitable way. So, for example, especially early on in the pandemic, a lot of communication was assumed a very high level of English ability, and so messages about appropriate preventive action, such as isolating after experiencing potential infection, hand washing, wearing face masks, etc. All of that type of public health messaging may not have necessarily been reaching all of the diverse populations of the UK. And lastly, we also know that many of the often necessary control measures that have had to be introduced within the UK are likely to also themselves have adverse consequences. So in this diagram, we can see at the far left in the kind of purple arrows, the direct harms of COVID in terms of COVID deaths and hospitalizations and so forth. But actually, due to the restrictions that are necessary to try to keep the infection under control, there's also likely to be substantial indirect morbidity and mortality as well. And a lot of that is likely to have affected more socially disadvantaged groups to a greater extent. So we can try and think about these different pathways resulting in adverse impacts of the pandemic on certain ethnic minority groups to a greater extent than others. And by trying to have an understanding of these different pathways and the actual mechanisms through which they operate, so issues like, for example, inequitable access to healthcare or insecure employment, a lack of capacity to isolate effectively at home, all of those types of issues are themselves likely to be driven by broader issues of structural racism. So it can be very difficult to actually investigate the impact of racism more generally, because actually a lot of the mechanisms are the things that we can observe, and actually observing the broader ideology of racism itself is very challenging. Typically, when people think about racism, they tend to think about interpersonal racism. So that's the idea of one person directly discriminating against someone else, for example, name calling or that type of issue. But actually, that tends to be probably a particularly uncommon form of racism, and also probably less important from a health point of view than the broader issues of how institutions are set up in a way that might embed policies that disadvantage certain ethnic groups. So that's often referred to as institutional racism. And famously, the police were accused of institutional race, or acknowledged themselves actually to be institutionally racist following the Macpherson report, which investigated the murder of Stephen Lawrence. And at a broader level than that, actually the way societies are structured may actually reflect broader structural racism. So apart from the research, what else has been happening in terms of government responses? Well, so within Scotland, there's been a Scottish Government Expert Reference Group on COVID and Ethnicity that's been set up. And in England, or rather at the UK government level, there's a subgroup of the SAGE, the Scientific Advisory Group on Emergencies. A subgroup has been set up on ethnic minorities as well. And at the Scotland level, the recommendations that have been made so far have focused on two broad areas. So firstly, actually, what can we do to improve data and evidence on ethnic inequalities in health? So a big issue within Scotland was initially a lack of data, and especially a lack of robust data to understand ethnic inequalities, with some of the initial analyses suggesting that actually COVID risk was lower amongst some ethnic minorities, whereas that turned out to be erroneous and actually a consequence of problems with the data. So there's a need to improve the way we monitor ethnic inequalities, both in terms of COVID, but also more generally. And that will be important as we start thinking about things like vaccination, for example, in the future, trying to make sure that we're monitoring uptake of effective interventions. And a second set of recommendations focused on actually what should we be doing to get the public health response right, both in the short term, but also in the long term. So how can we improve communications? How can we also address the broader underlying issues of economic insecurity or housing insecurity that might be exacerbating some of these ethnic inequalities? And in terms of research, some of the next steps we're taking are trying to look at linked Scottish administrative data. So we're planning to bring together census data to a range of different health data sets, so including hospitalizations, prescriptions, infection test results, and ambulance callouts and so forth, to better understand and monitor inequalities going forward. In a separate study led by Rob Aldridge at UCL, we're looking at a representative sample of people boosted for ethnic minority groups to look at how changes in social contacts and exposure to the virus is happening over time, as well as analysing linked administrative data within England. And thirdly, we're part of a larger group of researchers analysing large-scale survey-based data sets and cohort data to understand both the direct and indirect health consequences of the pandemic. So to conclude, there's clear evidence of marked ethnic inequalities in COVID-19. Importantly, these aren't just the same inequalities as what was observed before the pandemic. So in relation to ethnicity, it is quite a different picture. A lot of this increased risk seems to be down to a greater risk of being exposed to the virus and then potentially developing infection. But there's possibly poorer prognosis as well, but that's a bit less clear-cut. And hopefully I've tried to convince you that there isn't a single explanation for COVID-19 inequalities by ethnicity. Social inequalities are almost certainly going to be important. That doesn't necessarily mean that's everything is about socioeconomic position. Actually, there are other forms of broader social inequalities, and many of the differences in employment, housing, and so forth are likely to relate to broader issues of structural racism that are driving that social patterning. So the policy responses need to be multifaceted, probably with a focus on reducing viral exposure in the first instance, and there's some policy responses happening within Scotland, and hopefully to some extent at the UK level as well, with an official response due from the Scottish Government at some point soon. So thanks very much, and I believe we should be moving on to questions now.
Yeah, so thanks both to Vital and Claire. So I'd like to give a big thanks on behalf of everyone who's been here today listening to the seminar. Normally if we were all together, I'm sure everyone would provide a round of applause. And that was an excellent overview on research on ethnic inequalities and policy responses. And we've got about just over 10 minutes now for some questions. So you can do this in two ways. You can either raise your hand if you have a question, and I can unmute you and you can ask it, or you can add it to the chat function or the Q&A bar. And there was a question during the talk from Anthony Christie, and it was regarding Vital and Claire's your comments about structural racism being a possible explanatory factor. And Anthony asked, is there any evidence intention to gather information on institutional racism, such as ethnic minority staff in the NHS, as well as other sectors not being treated any differently? So despite the evidence of those inequalities, they're maybe not having the opportunity to shield by their employees. So I'll pass that to Vital.
Yeah, great. Absolutely. So that's an area where actually we did make some recommendations about, for example, within the NHS, but more broadly in the public sector, we know that often ethnic minority employees are less likely to be promoted. There's been some evidence to suggest that barriers to accessing personal protective equipment, PPE, especially early in the pandemic, was likely to be particularly important in contributing to the greater risks experienced amongst ethnic minority healthcare workers. So certainly many ethnic minority employees within the NHS reported finding it more difficult to access effective PPE. And so I think on the one hand, we know that within the NHS, there have been broader issues of racism over a long time. And so some of that will require longer term changes. But as well as that, there probably needs to be more short-term changes to occupational health, some of which are beginning to happen. So there have been some recommendations about, for example, making sure that there's a more proactive approach to ensuring PPE is available, which is inclusive to people. So rather than expecting people to kind of make a fuss in order to get their PPE, actually trying to be more proactive in ensuring that everyone has access to it.
Thanks, Vital. Helen Minnis has her hand raised. I'm going to allow you to talk, Helen. So I think you just need to unmute yourself.
Hi, thank you. That was fascinating. I'm a child and adolescent psychiatrist and epidemiologist, and I'm a person of an ethnic minority. And I've got a couple of questions. One is, I'm really fascinated by the stark change in inequalities during the pandemic. And I just wondered what your views were about, is this to do with this being an infectious disease, or is it to do with a stressed health system, or whatever else? And I'm also wondering, has there been any more discussion about vitamin D? Because I don't usually like being kind of lumped together as BAME, but this does seem to be a situation where there's something going on there.
Yeah, so Okay, so I'll take the second bit first, if that's all right. So vitamin D, I think, is almost certainly not going to be an important explanation here. So I agree. I think the lumping together of people under BAME is unhelpful. But in terms of vitamin D, there have been some, including the study that Claire mentioned, that there have been more recently Mendelian randomization studies, so using kind of genetic instruments to try and get at causation, and they found no effect of vitamin D on COVID risk. So I think it's highly unlikely that vitamin D is going to be important here. In terms of what's going on, so I think there's almost certainly not going to be a single thing going on. I think partly because this is an infectious disease, I think that is part of it. So I think often many minority ethnic groups have lower risks because there are certain kind of more protective health behaviors, if you like. So, for example, lower levels of alcohol consumption, often lower rates of smoking and so forth. So those things may not necessarily be as protective in terms of COVID, but instead, a lot of ethnic minority groups work in certain occupations which might be more likely to be at the front line. So healthcare work and social care work being obvious examples, but also things like working in kind of transport, so taxi drivers and bus drivers and so forth. So I think that's likely to be an important part of it. And in some analyses that the Office for National Statistics released very recently, I think kind of 3-4 days ago, they're finding that actually when we properly account for some of these differences in occupation and other social factors, that really does seem to explain an awful lot of the difference.
Thank you so much. That's fascinating.
Okay. I'm going to ask a question from Harry, which was, do you think the concept of health literacy could be a key issue here? And this maybe points to the secondary data as well. Is health literacy measured, able to capture within the secondary data sources? Could that be an issue?
Yeah. So I have to admit, personally, I always have slightly mixed feelings about the term health literacy, because on the one hand, I can absolutely appreciate that individuals are able to engage in kind of effective use of healthcare to differing levels. However, the way a health system is designed also influences an individual's kind of ability to engage in that system, if you see what I mean. So I think it's very difficult to divorce the idea of an individual's kind of health literacy from actually how the system itself is designed. So I think, yes, there may be kind of differing expectations about when should I be, for example, first seeking help for my potential COVID symptoms. But actually, that may also just reflect the way we've been communicating with people has not actually been meeting their needs. So we've not actually been very culturally competent in our approach to communication and in the way we've been designing health systems and health services. So the kind of rapid and understandable push to move a lot of healthcare to be kind of remote in terms of telephone communication and online communication is obviously necessary from a kind of COVID risk management point of view, but we need to make sure that we also, alongside that, ensure we have things like access to interpreting and so forth. So yeah, it probably plays a part, but I think actually there are things that we can do working in public health that mean that it shouldn't just be seen as that individual's health literacy.
Yeah, thanks, Vital. It's an important component, but not the overall component. So I think we've got time for one final question, which I'm going to read out. Iram's question, which is, how can ethnic inequalities and other infectious diseases be tackled using the same approaches? So what kind of policy action can make a difference between policymakers? And because ethnicity is self-reported, what can be done to incentivize people to report this accurately? As unlike socioeconomic status, there is no advantage of reporting this, such as social security protection. That's quite a broad question, but I wonder if you have any thoughts on it.
Yeah, so the first thing to say is in terms of data collection, usually the issue is that people don't get asked. And if they get asked, they often don't get asked in a way that explains why questions about ethnicity are being asked of people. So most of the research on this topic has found that actually people are very happy to report their ethnicity if they're asked and it's explained why the information is being collected. So for example, within NHS Lothian, they increased the rate of coding of ethnicity from around kind of 3 or 4% to around kind of 95% within a period of 3 or 4 years, largely through staff training. So it's usually about NHS staff in terms of health data anyway, not actually being confident in asking people about their ethnicity. Sorry, what was the first bit again?
Sorry, just try and refine the question. Whether this approach could benefit, and what we've learned here could benefit other infectious diseases.
Yeah, I mean, absolutely, I think it can. So within the UK, generally, we've not thought about infectious diseases that much. For a lot of our thinking is focused more on kind of non-communicable diseases, but actually, a lot of what I've been speaking about, I think, are probably things that many people who work in health protection day to day within public health organizations have an understanding of and do try to implement. I think some of the issues were actually improving things like income security that would help people to self-isolate if they're symptomatic, and improving job security and some of those types of things, I think are likely to not only have kind of relevance for improving like reducing infectious disease burden, but also probably improving non-communicable disease burden as well. So I think a lot of these actions would help improve health overall.
Yeah, they can provide learning for the whole society and public health, as well as just infectious diseases. So we've come up to 2 o'clock now, which is the end of the seminar, but I'd really like to thank Vital and Claire for providing this excellent oversight. It was a really interesting presentation, so thanks to you both for giving your time. The seminar recording will be on the SPHSU website, so you can see it there. So finally, just again to thank Vital and Claire, and that's today's seminar finished. So thank you.
Thanks.
Thanks. Great to see everyone. Bye.